We will just a few minutes before we begin, so the attendees can come in. We are also live on YouTube now. Okay, so just a couple of more minutes till people come in. Hello, everyone. We're just waiting a couple of minutes for people to join, and then we will begin. Okay, so we'll begin. Welcome everyone to our webinar. For those of you listening in on YouTube, just kindly type your questions there in the comment box, and we will relay them into the Zoom room and for the webinar. And towards the end, we will answer them. So whenever you come up with a question there, if you're watching this live stream, please just type it there in the comment box. We will be monitoring them. All of you here and all of you people attending in Zoom, please use the Q&A box if you have any issues or any questions at any point of time. We will be addressing those questions, and our panelists will answer those questions towards the end of the session. So the Q&A box, it's, you tap on the Q&A box, you will be able to type your question in. And once your question is typed, you can click submit. There is even an option to submit the question anonymously. And not that we've tried, but we're pretty sure we won't be able to figure out who you are if you use that button. So thanks. With that, I will hand it over to Mahin Ali Khan, Head of Communications, who will just introduce the Covid-Gyan initiative and kickstart this webinar. Over to you, Mahin.
Thanks, Chandu, and a very good evening to our panelists. Thank you to Sudhir, who has been instrumental in putting this together with us, and of course to Uma, who works with us at the Communications Office very closely to ensure things like this happen on a more regular basis. I just want to tell you a little bit about Covid-Gyan. So Covid-Gyan is, well, this is called a WebGyan. Let's begin there. This is called a WebGyan. This is a webinar series platform, which is part of a larger Covid-Gyan initiative. And Covid-Gyan, for those who don't know it, is a science-based website for information on COVID-19 with an aim to fight misinformation around the coronavirus outbreak and to educate the public by providing factual aspects of the pandemic. So IISc, TIFR, and TMC are just some of the collaborators of this cross-institutional pan-India effort. And apart from being a source of information, Covid-Gyan is also a go-to repository for information regarding COVID. So we've done a bit of a soft reboot in 2021, given the disastrous second wave. And we're hoping that this series of webinars is going to be of benefit to the public. And I think with people like Sudhir on board, we can ensure that we have some very interesting topics coming up and some very interesting points of view. So that's Covid-Gyan for me. I'm now going to hand it back to Chandrakant, and thanks everyone.
Thank you, Mahin. And the name WebGyan was actually Mahin's invention.
Yes, it was very creative, as you can tell. Covid-Gyan, WebGyan. It's quite a leap. Yeah.
Yeah. So I'll just ask Professor Sudhir Krishna to introduce the session.
Well, thank you. So this is our 7th public health webinar, and the 3rd one that we're doing in sort of partnership with IIT-Goa. We've had 2 ideas really. One is, of course, to contribute to the understanding of the pandemic and make a meaningful contribution on that front. But the other is to engage science and engineering campuses with public health. Public health deals with complexity. Public health deals with real time. Public health needs a narrative and experiences which are very different from the sort of reductionist approaches of science. The idea is not to actually replace one or the other, but to sort of bring the 2 of them together real time to create the capacity and leadership for the future. And that's been the idea of these webinars.
Sudhir, may I interrupt for a moment, please? Could you speak a little closer to the mic? Because your voice is sounding a little distant. Thanks.
So that I don't need to repeat myself. I've introduced the session and so on. So today we have 3 panelists. We have Varsha Sridhar, we have Vikram Patel, and we have Ramanan. Varsha is going to talk about surveillance. Vikram is going to talk about institutional structures, and Ramanan, I think, will focus on modeling and so on. The idea will be, as I said, to focus on the 3rd wave, and also how can we mitigate the 3rd wave, and how do we, to borrow a term from Vikram, how do we build better for the future? So without much ado, let's get started with Varsha Sridhar.
Hi all, can you see my screen?
Yes, we can.
Sounds good. Okay, so thank you so much, Sudhir, for the opportunity to talk about some of what we're doing. Thank you, Uma, Chandrakant, and Blisk and the NCBS group for this very nice invitation. Looking forward to an hour of lively debate and discussion. How do I go on? So I'm basically, go ahead.
Some of the audio is coming back again, that buzz.
Got it. So I'm an entrepreneur, a scientist, I'm a diagnostician, I'm excited by ideas. And I think most of what I do is driven by my own just seeking new things to learn. You can see more about me on the LinkedIn page. So what I really want to spend a little bit of time today discussing is the surveillance for COVID. Why do we need it? What are we going to be? What are the methods being used for it? Our own experiences with it, and the critical need for interagency cooperation. I would like to use this opportunity to call for data transparency and sharing. And I also want to talk about how we can actually use the learnings that we've had in the past year to build capacity for surveillance, not just within India, but also outside India. So epidemiological surveillance is really an ongoing longitudinal collection, analysis, and interpretation of health data that are going to be used for planning, implementation, and evaluation of public health practice. So really, what we are trying to be looking at is, where is the disease? What are its characteristics? Who are the people affected? And are there temporal changes in the disease and its manifestations? And what could be some risk factors or influencers of the severity of the disease? And the hope is that the sooner we can find out where the disease is and what it is and determine its nature, the better we can control it. Right now, COVID surveillance in India right now is quite top-down. The ICMR, which is the Indian Council for Medical Research, a central government body, it basically dictates and has laid out certain guidelines, which are followed by the state governments and local governments, and of course all the private parties that kind of work in conjunction with these governmental agencies. COVID surveillance has a multi-pronged approach right now. We are looking at rapid antigen, RT-PCR, and recently we've started genomic sequencing. Antibody tests were not used in regular surveillance so far, but they have been part of government zero surveillance studies. And although we have vaccination data with the CoWIN portal from about December or so onwards, it is not automatically linked to testing data. And this has been a bit of a gap. In terms of total number of COVID RT-PCR tests conducted, India has actually done a pretty good job. We are second in the world with about 0.4 billion tests conducted so far. And it has basically been a massive effort in capacity building across the country. And you can see the next one is UK, which is almost half of what India has done. This looks amazing. And this is actually something which people don't typically talk about, because we usually talk about numbers per 1,000 people or numbers per million people. And because of our gigantic population, those numbers are actually quite small. But still, 0.4 billion tests is nothing to laugh at. So I think we should be quite proud of what we have accomplished, and in a fairly short time as well. A lot of surveillance right now, when you're looking at, let's say when you're looking at a third wave, when do you know a third wave is coming? People typically look at total positivity rates or hospitalization rates. And I'm happy to share some of our lab data down the line. What we should, I think, however, be looking at also are other ways to track it, because positivity rate and hospitalization rates typically tend to give you rates as they are happening. There's no opportunity for early detection, and there's no opportunity for preparation for a next wave. You're basically like, oh, it's here, and then the tidal wave hits you. Perhaps we should be looking at sewage-based testing. This is something that Uma at NCBS was among the first people to start. We've also started that, and I'm happy to share some of our data on that as well later. We could be looking at drug sales, antipyretic antibiotics. If not drug sales, could we look at drug levels in the sewage? Could we look at COVID helplines and the number of calls that are going to these helplines, both government and private? Or could be looking at physician calls and what are primary care physicians really seeing at the ground level? This is some of our surveillance. This is the surveillance system that we've set up in conjunction with a number of other organizations through a group called the COVID Action Collab. And we started this as a pilot last year, sometime in June. And we got funding for it through Skoll Foundation and USAID. And then now it's a citywide program where we do twice a week testing, and the data, the viral loads of this is put up online. And we're also trying to sequence some of the stuff that we see in the sewage, and to see if we can actually map which wards in Bangalore have what kind of viral loads. And can we also look at what kind of variants are there in which part of the city? So for example, this is our dashboard. On the top right, you can basically change ward by ward, and then you can actually look at the viral loads across time. We started doing this end of April. So it's been about 2 months of data collection over here now. And we plan to do this for the next 8 months or so. I've talked about COVID diagnostics, but really COVID surveillance is not a linear process at all. We think about multiple different scientific and epidemiological variables that are tracked, but really that by itself is not the only thing that leads to diagnostics and surveillance. It's a very complex system. And the variables that go in over here are really government policies keep shifting. There are shifts in media, what the media tends to focus on and not focus on. And of course, the financing for this keeps changing. And as usual, you can't actually say if something is positive or negative. And a positive or negative depends a lot on the what's happening around, what's total positivity rate, what's a positive predictive value, negative predictive value, and so on. And again, one of the mandates, or one of the vision for surveillance is that people who typically don't have access to good quality health are perhaps now we may be able to prepare better so that they do get access. So many of the aspects of health quality and access, behaviors at systemic and local levels, all of them this is a dynamic system that people are constantly, all these things keep on changing, and therefore your output also keeps on changing. And really for complex solutions, then you don't need silos. You really need to be having multiple networks. For COVID surveillance, I think this is my personal opinion. I think you need multiple different ingredients to form a good surveillance network. This includes things like investors, because you do need money for surveillance, right? Where are you going to get it otherwise? And these could be government investors, these could be private investors. You need other partners and all these have to do with different types and who are willing to take on different risks. Technical expertise obviously are mandated, is like a requirement. Quality and TAT of solution, TAT meaning turnaround time. What's the time from the time you collect the sample to the time you get a report saying what have you found in the sample? If you're going to have a turnaround time of 3 weeks, 4 weeks, it's really kind of pointless to do any kind of surveillance. You really need to be looking at something that gives you answers in a day, ideally. Unless you have systems of communication, finance, and transparency, it's very difficult. And this is something that I've personally understood in the past year. Because when you have so many partners wanting or willing to work with each other, and the willingness also is of different types, right? Some of them are begrudging partners and some of them are active partners. But unless there is communication, there's very easily, the coalition has a risk of kind of falling apart, mainly because of poor communication or poor expectations of what the other person is doing, and also different pressures by different stakeholders. You have to have government buy-in. Without government buy-in, there's no point of any surveillance. And there has to be scale. You can't be doing it at one tiny place. It has to be at a city-wide level or a district-wide level, something like that. Okay. I had said I was going to use this opportunity to call for data transparency and sharing, and I'm going to do that. Basically, right now, we have a lot of data. Like I said, we have 0.4 billion data points, at least, from the RT-PCR tests that were conducted in our country over the past year, maybe 14, 15 months. Much of this data is hidden, right? You can't really independently analyze it. One could argue that maybe this has to be anonymous, there could be data privacy issues, but I think it would be possible to anonymize it. But now, because this data is entirely within one or two bodies, the rest of the country, it takes a long time for us to know what's going on. And there is no independent analysis of it, which means there's always going to be some amount of scientific, that amount of scientific dialogue that is required for high quality data and insights to come out is not happening as of this point of time. Genomic sequencing as well. Labs require permission by the ICMR or a group called the INSACOG, which is fine. They have laid down guidelines for quality and stuff like that, but the permission processes are non-transparent. And so far, at least, private labs have not been given permission. And why do I stress on private labs? That's because I think most private labs have processes to have larger throughputs and lower turnaround times than most government labs, just because of the investments that have gone in already. Sequence information also, if your turnaround time is going to be 3 weeks to find out one variant, it's kind of pointless. Anecdotally, I've heard that many government labs do send their own samples to private labs for sequencing, which again comes back to the question as to who are the people who are getting permission and why are they getting permission to sequence. With that, I'm going to come to the last point of my talk, which is basically capacity building for surveillance. This is the positivity rate across the world as of June 5th. India has basically sort of right now come out of its second wave, and if we have we're in blue, thankfully. But you can see there's multiple parts of the world which are still in red. And a lot of them are white, maybe because they don't have the capacity to actually test as much as they should be. One of the things that I've been fortunate to see over the past year is the increase in access to the RT-PCR test. In blue are the government kind of mandated caps of the test price. So last year in July, it was 4,500, and now it is 800 rupees, which is less than, I think, $10 or about $10, something like that. The RT-PCR kit prices used to be 800 rupees at one point of time per sample, and now it's come down to less than 100. So you can see that whatever it is, whether it's a policy decision at the top that forced these prices to go down, whether it's innovations in manufacturing and scaling and in distribution, whatever it was, somehow we've kind of pushed certain things to go in a particular way that this test is actually really affordable. 800 rupees, even if it's not affordable by the lowest members of the society, it's still considered to be, you can still get it for free in government settings. So this kind of rapid, I think, innovation, I don't think has actually happened in our country for any health-related issue before. So how do you ensure that your community is responding to whether it's new pathogens or old pathogens in a different flavor or other environmental harms? It's not, we can't just kind of, no country is an island, no man is an island, as John Donne says. So it's not just enough for us to enhance our own capacity. I think as a country, we've learned a humongous number of things in the past year, and we really need to be productizing these learnings in capacity building. Okay, you don't have, if productize is a word that you cringe from, we really need to be packaging our learnings in a way that it can be scaled and it can be kind of taught to the rest of the world to make testing accessible across the world. And that is all I have to share. Thank you so much.
Thank you, Varsha. We will now move on to Ramanan. Sudhir, would you like to say a few things before we move on?
No, actually, I just thank Varsha for a very, very good practical presentation. In fact, I think one of the points I'd like to flag is the product policy issue, and I hope the panel will take that up later. That does policy take product development enough into account? But we'll go ahead with Ramanan. Please go ahead, Ramanan.
Sure. So these are rather hastily put together slides, but these are two studies that we've published out of a series that the second one is actually just about to come out this coming week. So I wanted to talk about the fact that although testing has lagged and so forth, there has been a significant amount of data coming out of India in terms of the epidemiology of COVID, particularly because contact tracing has actually been quite remarkable in some states. So we were able to follow about 4 million people and then get very detailed data, almost 700,000 of them for this study that was published last year. This was the largest study to date of COVID-19 transmission, still is. There hasn't been one. And as you can see, that's over 3 million people traced, 5,700 deaths, and really informed a lot about what we understand with respect to children transmitting COVID, super spreading, and so forth. So these data come from Andhra Pradesh and Tamil Nadu, and as you can see, mostly when the early wave, May through July, when COVID was spreading. I mean, this is not forthcoming. This has been out for a while, and we had detailed district level data. In fact, we had the individual data that went into this. And Andhra Pradesh was a little slower than Tamil Nadu in catching up, but at the end of the day, both states had significant epidemics. And so we had the cumulative incidence and mortality by state. And you can see it was going up quite sharply in the beginning and then leveled off after the lockdown. So when you first look at disease transmission, the contact definitions that are used in these states are high risk versus low risk criteria. High risk criteria, you touch the bodily fluids of the index case, you have direct contact and so forth, or you're sitting very close to them in transportation. The low risk is that you just share the same room, or you travel in the same conveyance, but you are not, within a few rows of them. And we found that trace contacts tended to be younger, more often female. Test positive individuals were on average, a little younger and less likely to be male. So this is the most important part, which is the secondary attack rates, which is if you are exposed to someone who has COVID, what's your risk of getting infected? This is something which everyone always wants to know. And that answer is that it is roughly about 9%. So, because the most common contacts are happening in, it's anywhere between 7.5%, 8%, 9%. This is typical for what we've seen in studies in South Korea and China as well. Obviously, it's higher for high-risk contacts, but you can see that your risk of getting COVID in that first wave was about 9% in the household, much higher if you traveled within 3 rows of the other person, but much smaller out in the community, only 2.6%, only one in 4 getting COVID out in the community. Now, if you look at the distribution of index case ages and the distribution of contact ages, you see a significant clustering that, the index cases tend to be in that 20 to 40 age group. That's where, that's where most people are going out because of that age group that was traveling out even during the lockdown and so forth. And this is the distribution of contact ages. And what we see is that when we look at the index case ages by infected contact, you see a significant 45-degree line here, which means that people are generally infecting people of their same age group. So if their index age is in their 40s, then the infected contact age also tends to be clustered in their 40s. This is not unusual. Now, there is obviously some spillover into other age groups as well. And as you can see, the people in their 20s and the 40s are infecting people at all age groups. You see particularly this cluster where they are actually infecting young children. So children were infecting each other, but more often the adults were infecting the children. So you see these clusters over here. And prior to this, we didn't really understand what the role was of children in transmission. And we thought they get infected as much, not true. They actually get infected just as much as else. And in fact, if you, the economists put this into this very nice picture, which looked at age of infected person and age of people subsequently infected. And again, this very remarkable 45-degree line, which sort of says something different from what common wisdom is, that people in India transmit COVID to people in other age groups. Children are coming in touch with elderly populations, not really borne out by the evidence. What we typically find is that even in contact tracing studies, even in India, there's not as much intergenerational mixing of people, even just in a non-disease sense, but certainly when it comes to diseases, people are far more likely to infect their own age group. So this idea of somehow people, the elderly were protected, because they were in their households, and not protected. All these are, not really borne out by the evidence. It's really that, people are likely to infect people in their own age group. Now, superspreading is one of these phenomena that, again, people carry something vividly in their head. They think of it as this kind of a situation where someone goes into the market and spreads to many other people. That is certainly true. And this obviously predates the superspreading that likely happened in the Bengal election rallies and also the Kumbh Mela. But we did already have superspreading events at the Tabligh Jamaat events and also at the Coimbatore supermarket, the vegetable market in Chennai. And, there have been other instances of this in other places, whether in prisons or hospitals or football matches, as you'd expect in Italy. And basically, the idea of superspreading is that a small proportion of people account for a large proportion of infections. So actually, there's not 10, it's more like 8. 8% of people caused about 60% of subsequent infections. And 70% of people who tested positive did not infect anyone else. And this is something to keep in mind, which is that not everyone who's COVID positive actually infects other people. Now, this has been true in other parts of the world as well. So this is data from Hong Kong showing that the sporadic imported cases account for the bulk of the cases, and then there are only smaller clusters that have been initiated by a local case. And in fact, if you look at what spreading looks like, the vast majority of people are spreading to 1, 2, 3 people max, around them. There are these super spreading events which are much rarer. And in this particular case, there's someone who spreads socially to many people, and then they spread to their families and a couple of work situations. But these tend to be unusual. The more common one is just spreading to 1 or 2 other people. And we've seen some of these unusual events. This was the ski village in Austria, which resulted in cases in many, many countries afterwards. But these are not the norm. And in fact, but it does happen, which is why COVID, when you look at the K value, it's more like here, like SARS, and not so much like all these other diseases. And in a homogeneous population, the proportion of infectious cases is the same is 45-degree line to the expected proportion of transmission. So it is a super spreading is now well established in the case of the SARS-CoV. And the whole idea is that when you know this, then targeted control policies can do a lot better than just population level policies, provided we can identify these predictive correlates of higher infectiousness. Now we do see that there's not a there's a big difference between high risk and low risk contacts, but not between male to male to female, female to male, and female to female. And this is something I just showed earlier in the picture, which is that children much more likely to transmit to children, again in the 5 to 9 age group, 10 to 14 age group, 15 to 19 age group, all the way to the 80s, that people are transmitting much more to their own age group. And sorry, I just repeated that slide. Now I'm going to present some things on mortality. These were the adjusted hazard ratios of mortality from exposure. I'll show this better in the next slide, but basically you can see that your risk of mortality is much, much higher in the older age groups than it is if you're a child. So this really is what defines COVID, right? Which is that old age is really definitely a risk factor. But we also find that as the date of testing got pushed into the future, there was a reduced risk of dying. And perhaps because clinical care was better, hospitals knew how to take care of patients. So in fact, if you got COVID earlier rather than later, you were at higher risk of mortality. In fact, that also explains the difference between Andhra Pradesh and Tamil Nadu. Tamil Nadu actually had far more early COVID cases and then ended up with more mortality. And again, this is the actual case fatality ratio, this number that everyone talks about, but these are one of few studies that actually have the data, which is not very different from what you have in other countries, but I'll show you that in. But just keep in mind, your chance of dying of COVID, if you're above 85, if infected, is 100 times that of if you're in the 0 to 4 category. So the case fatality ratios are vastly different. But if you look across different countries for the same age bracket, again, it's a myth that Indians have lower case fatality ratios. In fact, in the higher age groups, we do, and that's probably because of a selection effect. If you've reached these age groups in India, you probably are fitter than the norm population in other places. But once you get to the below 70 age group, this last line is India, and you can see that the case fatality ratios are much higher. In fact, 40 to 49 age group, this is really not the most favorable at all to be in India. Your case fatality ratios are much higher than in other countries, similarly 30 to 39 as well. So age-adjusted case fatality ratios in India are actually higher than the rest of the world. But of course, part of the obfuscation is that people talk about aggregate case fatality ratios, which have no meaning at all, because obviously we have a country that's mostly under the age of 35. So if you have a country that's mostly below the age of 35, you're going to claim a very low case fatality ratio, but that is not indicative of the reality at all. You have to adjust by age group to do it correctly. I won't go through all this text, but very simply that this study from Madurai is just coming out in Lancet Infectious Disease this coming week. And this was an interesting study because in this study, we had access to people's comorbidities even prior to them being tested for COVID. This was a citywide experiment where the authorities would pull people out if they had any reason, whether symptoms or they'd come in contact with someone else, and proactively test them. You were not expected to show up on your own. They would pull you to a fever clinic and test you. And we had the detailed data on this testing as well as the infections. So you can see at that time it was about 3.6% test positive fraction. And so people who are tested either because of travel, they had a known contact, because they were frontline health worker, et cetera, et cetera. So we had very rich also on why someone was getting tested. That's also reflected in these lines. You can see that this pink part is all people who had symptoms, some who had traveled, some because they had a known contact, and then there were unspecified reasons. And you can see that this wish for a test, which is just people wanted to get a test, presumably because they wanted to travel, that starts getting to be quite high after 9 September onwards, because until this period no one was actually traveling. They were all coming in either mostly because they're symptomatic. Now, predictors of infection, you can see that older age is actually a very important predictor of infection and an important predictor of symptomatic and asymptomatic infection. So you see that just being old itself puts you at greater risk for infection. Now, the symptoms predicting infection, this again has not really been reported elsewhere, which is that fever alone has a pretty high odds of predicting COVID. But in every instance, whether it's cough or pharyngitis or rhinitis myalgia, having that along with fever is far more predictive of COVID than without. Now, interestingly, in the study, we found that comorbidities also predicted infection. So remember, we're looking at people who we knew the comorbidities, same set of risk factors, and you go out there and see if they are positive or not. And you see that people who are diabetic actually are at much higher odds of predicting infection. Similarly for hypertension, respiratory disorders, but not for some of these other conditions. Again, at first, we hadn't really expected to think that comorbidities would actually predict infection, but that is really the case. I don't know if I have time to go through all of these, but let me quickly say that comorbidities, put you at greater risk for non-survival. In fact, if you look at this picture, you look at all ages, male and female. Here you're looking at days from the test, and you're looking at the youngest age group. Then these are the two middle age groups, and then the older ones. And in every age group, you see that having comorbidities, which is the red, vastly increases the risk of mortality compared to not having the comorbidities. And the risk is obviously high for males and females in terms of the differential. So, if we're looking for why a lot of people died in India, whether first or second wave, it's really got to do with these comorbidities. And you can break it down by diabetes as well, or circulatory disorders. These are the higher risk of dying. Similarly, for chronic kidney disease, respiratory disease, endocrine disorders, and cancers, you really don't see that much of a difference between those who died versus not, who had cancer versus not. So last thing I'll stop here to say is that we did, for the Madurai study, because we had very careful data, on people who were infected and comorbidities, we looked at their case fatality rates compared to other countries, and overall mortality, appears to be, different in different countries. But you really look at mortality amongst Madurai cases reweighted by the age and comorbidity distribution of, say, the US. This is what you should really look like. The case fatality ratios were actually much higher than they were in the comparison population, which is, say, the US or Italy, for instance. So, and if you looked at it just reweighted by age distribution. So this is to say, if people in Madurai had been the same age distribution as the US, what would their case fatality risk have been? And you can see, again, the answer to that would have been significantly higher than this. So anyway, I'll stop here. I'm just going to say this last one slide, which is there have been questions about whether the lockdown made any effect or not, had any effect or not. And I think there's very good data that the first initial lockdown really knocked down the number of infections. And but for that, we would have had a terrifying first wave itself. So there's more on this, but I'm happy to answer questions later. Thank you.
So, Raman, two questions that maybe you can take up in the panel. What is your sort of sense of the third wave? And the second is, what is the implication of your data for thinking about vaccination strategies? Because if you look at the Indian vaccination strategy right now, there's a sort of preponderance of people who had the first shot, much smaller number of people who had the second shot. Should we be targeting vulnerable groups, or are there ideas that you have on how we can fine-tune the vaccination strategy?
Sure.
Points that maybe you could come up in the panel discussion, but we'll now move on to Vikram right now, who's going to talk about institutional issues.
Yeah, well, thanks a lot, Sudhir. So, first of all, let me start by saying I'm not going to be referring to any particular study or piece of science, but actually on the role of institutions and the broader meaning of this epidemic in India. And I want to sort of start my remarks by saying that very few countries, if any, have really been able to manage this pandemic in all its dimensions. And of course, as I'll refer to in a moment, a pandemic is not only the number of cases, but actually much more complex than that. Whether we talk about accurately predicting each wave of the pandemic, averting mortality to the lowest possible fraction, and making sure that this is proportionate to every subgroup in the population, and minimizing the economic and social disruption consequent to containment policies and lockdowns. But from the experiences of many of the countries that I watch very closely, particularly those that have come to have reached closest to this goal, there are, at least for me, a few lessons that I wanted to emphasize. The most important lesson for me, and this is a lesson that's more than 100 years old, so it's not a very new one, it's just surprising that we simply don't learn from history, is that context and equity are critically important, and that a pandemic cannot be seen only as a medical crisis, but as a crisis both of care and, importantly, as a portal to exposing the fissures and unequal social structures of a society. And if, as your webinar is really focusing on, is how does science connect with society, well, then I think this is the fundamental message. We have to step out of our labs and of our various different specific research disciplines and examine how the different kinds of strategies we are proposing will impact on broader human well-being. Let's make no mistake, there were catastrophic human consequences of both waves of the pandemic, but for very, very different reasons. And in order for us to interrogate this, we're going to have to go beyond narrow metrics that are related to the infection and really leverage an interdisciplinary response, particularly beyond the narrow biomedical framework. Here I'm referring specifically to the critically important roles of supportive care for the vast majority of the ill. This is the single most important intervention for survival. Yet, where are the voices of nurses who are the foundation of supportive care for all kinds of supportive care, not just for COVID? I'm also referring equally to the voices of the humanities, of social scientists, who, even if our political masters were blissfully unaware of this fact, would have foretold the economic impact of a lockdown in a country where 3/4 of our people are daily wage earners. Any social scientist would have cautioned against the kind of brutal, unplanned, completely without any warning, and the total lockdown that we witnessed in March of last year in a country with such huge vulnerabilities. At the very least, they would have argued that any such containment policy must have been accompanied by measures to prevent the acute impoverishment which have affected large sections of our population, which were least able to cope with such an economic sledgehammer. I'm not at all surprised that many biomedical scientists, not just in India, but actually across the world, and the upper classes vociferously supported lockdowns. After all, most of our community, and I include myself, the upper classes, the scientific community, the academic community, and government officials who conjure and implement these policies enjoy salaried jobs, which can seamlessly pivot to online platforms for both ourselves and our kids, which we can operate from the ease of our very spacious homes with good internet connectivity, and which can ultimately evolve into a rather nice opportunity to actually work from home, not having to commute, and to do a variety of other things, including Zoom yoga and becoming great chefs. Across the world, we witnessed a great erosion of trust, both in governments and in particular in our own discipline, that of science, at least in part due to the lack of such a broad vision on what a pandemic means to ordinary people and how it should be addressed outside the narrow biomedical prism. In addition, trust has been eroded by the bitter politicization of behaviors like masking or getting vaccinated, the conflicting messaging within the scientific community, for example, most recently on the safety of vaccines or the use of ivermectin, and perhaps about a year ago on how we would realize herd immunity. This is before the vaccines came along. The often quite inaccurate predictions made by science about what was to happen and the deadly consequences of a totally unaccountable healthcare system, and we've seen this in the second wave, both private and public, I should emphasize, leading to massive levels of avoidable mortality. I believe the excess mortality that Ramanan has shown is probably a huge chunk of it is what's completely avoidable mortality, and the additional mortality due to the lack of access to essential health services, as well as irrational medical interventions. We've seen so much of that in the last few months. Trust is critically important to control a pandemic. It's not just about top-down policies and scientific advice, but actually engaging communities. Because without trust, communities will simply not follow the recommendations of the political scientific class. So what might be some of the strategies, the key question that you would pose to me, Sudhir, is, looking ahead for the third, mitigating the third wave. And I think there are a few things that I have thought about, and these are just speculations, and I'm going to share them with you now. First of all, I think what's very clear is the pandemic must require a response which is apolitical, which must reach across party lines and also across the center-state divide. so that policies are not influenced by ideologies, but by science. And I'll refer to science and what I mean by science in a moment. And that are delivered to the entire population with the least dissonance and conflict. A pandemic leadership group which comprises representatives of diverse political parties might be one way to realize this goal. And I still think there is enough time for us to constitute such a leadership group. But of course, this political group must be accountable to and must be informed by and respond to a group of scientists and scholars who, and this would be my second important instrument of policy. But when I talk about scientists and scholars, I think we have to look beyond, and I think Varsha alluded to this, we have to look well beyond the central government's entire focus on its own agencies like ICMR. We must acknowledge and recognize the rich capital in state organizations. Across the country, many states have incredible institutions, but also the NGO sector, the civil society sector, which also is home to some of the most important research institutions in the country. In addition, of course, we need to emphasize that this scholarship must include subject-specific scholarship, expertise in infectious diseases, particularly relevant to the specific kind of pathogen that we're dealing with. We must also make sure that this group isn't only comprised of narrow biomedical perspectives, but also expertise in supportive and critical care, and of course, I want to repeat, expertise in the humanities. In the longer run, I think the pandemic is a wake-up call for creating a permanent body comprising such a diverse group as many countries have already done or are considering doing. Relatedly, Sudhir, I think that what our country also greatly lacks is an institution similar to NICE, the National Institute for Clinical Excellence in Britain, which is an interdisciplinary group similar to the composition that I just described, which works independent of the government, independent of industry, and independent of the medical sector, and whose role is to recommend which interventions, both preventative and related to treatment and care, have sufficient evidence for backing their use in the health system. And of course, it is then important to ensure that only those interventions are used. And I think, recently the whole controversy about the use of ivermectin and other medicines reminds us of why we desperately need such a structure in India. The third important strategy is regular and consistent communication to the public. This is, of course, essential. And I believe that this can be managed if the first two sectors, the policymakers, apolitically united, and a cross-section of scholarly and scientific disciplines, they are now communicating messaging by close alliance with the media, appealing, of course, to the media's central role in influencing behavior change. The guiding principles of communication has to be, and I think we've heard both previous panelists speak to this, the transparent sharing of data on a regular real-time basis, and the use of these data to really provide the rationale for decisions that are being made. But equally, I think we need honesty in acknowledging the uncertainties in our data so that we're also able to say, this is what we know, this is what we don't know, and the actions we're proposing are based on our best estimates of what is good for this population, rather than what I think has happened quite all too often, this kind of sense of we know exactly what's going on, and therefore this is what needs to be done, often to be proven completely wrong, and as a result, further losing trust in science. And finally, and certainly not the least, I would strongly emphasize the role of civil society and civil society organizations, again, without any political bias or prejudice, because it is these organizations that have the power and the capability not only to mobilize communities, but also to be very important as a conduit for social interventions and supportive care at home, which, as we know, is what 99% of people with COVID actually need. To work with the local health sector to ensure that there are clearly defined triage pathways for care, and ultimately to protect the most vulnerable. In conclusion, at the heart of these recommendations, there is my observation that a pandemic is as much a health crisis as a social phenomenon. And our approach must be a combination of top-down imperatives, which has dominated India's approach, and indeed I'd say this is also true of most other countries, but also a bottom-up approach, one which must be inclusive and diverse and above all participatory of the community. I'll stop my remarks there and hand back to you.
Thanks, Vikram. That is very good. Uma, will you take over the panel and get Jayanti also on board so that you can now. Chandrakant, could you organize that, please?
Sorry, I didn't hear what you said, Sudhir.
Chandrakant, could you get Uma and Jayanti on the panel, and Uma can now steer the discussion.
Uma, over to you.
Okay, thanks. So thanks all for those really interesting and diverse set of talks. I guess Sudhir had posed some questions. Maybe we'll start with Ramanan. The question he posed, do you remember, or maybe we can ask Sudhir to repeat?
Sudhir, can you repeat that question? Sorry.
Yeah, I wanted to get a sense from your transmission data and other data and models. What do you think about the third wave? And the second is, do you have a comment on the vaccination strategy in India right now?
Oh, right. So, see, the third wave is entirely endogenous, as the first and second wave were. What I mean by that is that it's determined by what the policies are at the time when the wave is taking off or prior to it. The first wave was the way it was because of a lockdown. Now, obviously, the way in which that lockdown is implemented left a lot to be desired. But let's be very clear that in the absence of a lockdown, India would have suffered greatly last year itself. Now, the second wave was the complete opposite. There was, it was frankly fanned and encouraged by the leadership, and that's why it ended up being that way. Now, to predict what will happen with the third wave, one will have to predict how the policymakers will respond to a third wave. Will they be proactive? Will they, allow rallies to be held, or will they be a lot more careful this time? And I suspect that if they are, I suspect that they will be more careful, having suffered greatly during the second wave, at least the people did. And if we approach a third wave with caution, there is nothing fundamentally that it's going to get out of control, because second wave was also a highly transmissible variant, which also accounted for the way things were. On vaccination, I think my slides are sufficient proof that it was a mistake to have tried to vaccinate the 18 to 45 age group. There was no need to have gone after that age group at all. They're not really at risk. The age group to really focus on is people above the age of 40 or 45 who have comorbidities. So if you really want to prevent deaths, if we can get that group vaccinated, and the idea behind vaccination is always threefold. First, you try to save the life of that person, and then you try to save, prevent transmission. And then third is you try to get to some sense of herd immunity. We're obviously a long way from the third part. But I think if we could reorient our vaccination to just being on older people with comorbidities, no matter where they are, we will save a lot of lives. But today we're wasting a lot of vaccines on that 18 to 40 age group, which forms a bulk of India's population, but is at very low risk of dying.
Uma, maybe we could just finish the question that I had for Varsha too, and maybe Vikram can come
Yeah, sounds good.
Is there a gap between product development and policy? Policymakers spend enough time understanding the sort of nitty-gritty issues of product development? And this is my question to both Varsha and Vikram.
Sorry.
Sudhir, your voice is a little faint.
Right. So this is my question to both Vikram and Varsha before we move on to what you might have in mind. Is there enough feedback from product development people to the policy makers about the real issues of product development? Because one of the clear issues that comes out in the pandemic is that you need vaccines. My own comment on Vikram's equity point is that unless you have distributed manufacturing all over the world, you're not going to have equity as one of the outputs. And so, is there enough feedback to the system about the challenges of product development, whether it's RT-PCRs or vaccines, serological tests, and how do policy makers respond?
Do you want to go first, or should I go? Either way is fine by me.
Varsha, go ahead.
Okay, so it is, I don't want to sound pessimistic here, but product development and whether it's a kit or a VTM or a scene, still need talk. my conversations with the manufacturers of RT-PCR kits, for example, have always been that some guidelines that are given. Not everybody entirely guidelines have multiple.
Varsha, we'll come back to you a little later in the interest of time.
The path to what kind of.
Varsha, we're having some problems.
Say that again.
Yeah, Varsha, please stop the video. So I'll just switch off the video. And yeah, there's a bandwidth issue. So if you could,
Okay.
Yeah.
Can you hear me now? Is this better?
Yes.
Okay. So just to repeat what I said, it's a very top-down approach. There's very little understanding or transparency as to what exactly the guidelines are. For instance, there have been multiple innovations in testing, such as saliva-based, better antigen tests, which have not really made their way to India yet. This is despite the fact that Indian manufacturers or product developers have been making these products since August of last year. None of them are actually in the market yet because none of them have got approved yet. Now, you would think that in a country where most of the testing is restricted to urban settings, for example, testing in rural settings, testing in tribal areas are very, very low. Perhaps, but the other thing also is that people don't want to get poked in their nose or down their throat. It's a horrible experience. If you have something like a saliva-based test for pediatric patients or something like that, it would be so much easier. But it's still not been this thing. So who are the people making the policies and why? I don't think there is absolutely any clarity on that. Similarly with the vaccines, again, I would not be the right person to talk about it. But what I have heard is that there were very realistic expectations of the vaccine manufacturer of the country. You're going to have a vaccine by August 15th. Obviously, those are things that raise expectations and dash them without any kind of feedback from the person who's actually manufacturing it. So that would be my 2 cents there.
Thanks, Varsha. Maybe Vikram, if you could.
Uma, I'm going to anyway get Vikram to do closing remarks, so you can defer maybe Vikram's, and you go ahead with questions that Jayanti and you might have, and I'll get Vikram to do the closing remarks.
There are some questions from the audience, but maybe Vikram will hear from you, and then we'll go through them. That's.
Well, yeah, there are questions from the audience. I've seen those in the chat box, and I think one of the interesting questions that I'm looking forward to Ramanan's response is about whether access to healthcare was one of the factors that might explain the different case fatality rates. And I want to just say my closing remarks is, how can India build back better? Regardless of whether we have the third wave, let's be honest, India is the home of all kinds of epidemics for the last 100 years. So, this is just the latest one. Maybe it looks very deadly, but in fact, the truth is more people in India die of myriad other infectious diseases before COVID came along. So let's not for a moment think this is the most deadly infectious disease that's hit India. It's hit India in a very acute way in the last few months, but God knows more people die of TB every year than one would ever have accepted. So I think what the pandemic has simply done has exposed the fundamental weaknesses of our healthcare system. And I think we all know what those weaknesses are, so I won't repeat that. And I think if there's one thing I would call for is that this is truly a historic opportunity for us to really hold the state accountable for its complete failure of stewardship of our healthcare system, the complete failure of any form of accountability, and the complete failure of any form of transparent, routine monitoring of health. I mean, let's be honest, these questions about how many people have died is in part because we actually don't know what people die of in India to a large proportion of our population even before the pandemic. These are not new problems. These problems have been around for 70 years. The pandemic has only thrown them in full relief. And I think if there was a solution here, this is a oft used and overused acronym of universal health coverage. It could not be more relevant at this particular point in time. And in my view, that has to be a collective collective focus of action at the level of all policymakers, but also the level of citizens in our country to make sure that we turn this disaster into an opportunity for building back better, a much stronger health system.
Thanks for those thoughts, Vikram. I just,
Can I just, so
Go ahead,
Vikram,
Ramanan.
just to correct you, there are the India has about 80,000 reported deaths from TB, 80,000 per year. Even if you correct for the estimates, about 400,000. So not true that COVID is small compared to other infectious diseases. In fact, COVID's mortality is all of the other infectious diseases put together is probably exceeded by COVID deaths last year. So let's not, this is actually quite a significant event.
No, Ramanan, that's last year. COVID, TB has been killing for 100 years. The question is.
I'm saying for the last year. So let me finish. Let me finish what I'm saying. So for the last year, COVID has definitely killed a lot more people than these other infectious diseases put together. The second part is that the reason why we focus on these infections is because the vast burden of avoidable mortality is in these domains. I mean, although NCDs do kill more people than communicable diseases do, the avoidable mortality is much higher from the communicable diseases, which is why we really can't afford a repeat of COVID, nor does it make sense to minimize it, because as the US has shown, unless you deal with COVID, there is no recovering the economy. People are not going to go back. No one's going to come back to real form. So the emphasis on COVID is appropriate for that reason. I fully agree that India should have built a much better health system, should be building a much better health system, all of which, regardless of COVID, no question about that. But at the same time, if we don't deal with COVID, we're not going to get to any of these other things.
Thanks for that, Ramanan.
I can also answer the other two questions very quickly. The one that I see here. One is that the 30 to 40 age group, two reasons why it's wrong to vaccinate them. I mean, I'm not saying wrong to vaccinate them. If you have enough vaccine, vaccinate whoever you want. But when there's a trade-off and you had to vaccinate someone who would die without the vaccine and someone who's going to potentially transmit, I would still prioritize the people who would die without a vaccine and prioritize them given that the skew in age-related risk of COVID mortality is so high. So in that prioritization, we should go after the elderly first, and then the ones who are transmitting. But again, keep in mind that our evidence on reduced transmission with vaccination is still, kind of being developed and still iffy. So I would still prioritize people dying and then the people who are transmitting. And last was access to healthcare factor. I mean, there's no way to factor it. These are the case fatality ratios. And clearly they show that any number of things, whether it's a higher risk of, comorbidities, poor respiratory condition, the fact that we have so many other insults in life, in India in terms of poor nutrition, et cetera, and then on top of that, the access to healthcare, all put together, and of course the absolutely terrible clinical guidelines, which I feel have done as much damage as COVID itself. I think that's the reason why the CFRs show up so poorly in India compared to the rest of the world.
Thanks, Ramanan. And I guess Vikram has to leave, unfortunately. But we didn't get a chance to hear from Dr. Jayanti. I'm sorry, Dr. Jayanti, would you like to add something quickly before Vikram leaves or while he's exiting?
Okay, so I am from Mumbai, and I head the reference lab in Mumbai for molecular diagnostics. And we had some opportunities to conduct sero surveys in Mumbai, both in July and August of 2020, where we did it in 3 wards of Mumbai. Mumbai is divided into 24 wards, and we divided the population into slum and non-slum. And when I say sero survey, we used the chemiluminescence platform for estimating antibodies. We used the Abbott platform last year in 2020. And we saw that there was a fall in the antibody levels. In the slum, it was 57% and 16% in the month of July. And in August, it was about 45 and 18%. Again, we conducted sero survey 3 in the month of March 2021. This was just before the second wave. And in this, we estimated both the nucleocapsid antibodies and the S1-RBD antibodies using the chemiluminescence platform. And what we saw was about the non-slum, as we talk about the high rises, had gone up. It was about 28.6 and 41.6%. In the month of April to June, we conducted the pediatric sero survey. And that we did for 18 and below. And I just wanted to end on a positive note that it was, the results were very good. And 10 to 14 years was 53.43%. Overall was 51.18. This we did in 24 wards of Mumbai. And the public sector, we saw about 54.3 and private sector 47.03. So this, in fact, has sort of brought to light that the pediatric population has been exposed, and therefore disproportionately, if there is a third wave, they are not going to be affected. Now here, this is a platform where I would like to share that we do a lot of neutralizing antibody testing also in my lab. And what I'm really surprised is, why don't we have access to good quality neutralizing antibody kits, which are available in the US and in Europe? Because we are part of a number of programs where we listen to the WHO meetings, and there always it is, we need a good surrogate virus neutralizing test, because the one which we have, like the GenScript assay, is also detecting the non-neutralizing antibodies. We do not have access to PRNT, and PRNT is very labor intensive, and as many variants crop up, you need to look for the efficacy against all those variants. So I thought that this was one thing which, since we've been doing sero surveys and neutralizing antibodies, this seems to be a roadblock. The other thing which I want to bring to light, I really enjoyed listening to all the speakers, it is the death reporting. Death reporting across states in India is variable. I know for sure that Maharashtra has been pretty true about reporting deaths, but that also sometimes, I feel that there is a disparity. But when you talk to people from other states, you realize that, a lot of deaths are not being reported. So how do you go about ensuring that, across India, reporting has to be the same? The number of RT-PCR tests, of course, is captured very well by ICMR, because you can't issue a report without entry in the portal. But death reporting is, I feel, across India is variable. Thank you.
Thanks so much, Dr. Jayanti. And I guess, it's been nice to hear very different perspectives. I really like the challenge that you've set us, Vikram, about this interdisciplinary, panel, which is independent of the state. It seems like a dream, and I hope that this is something which we can really move towards in India. I know everyone's out of time, but maybe another day we should think about how, and not just what, but how can we actually get there. I don't know whether, Sudhir, you want to say anything
Go ahead.
as we conclude.
Go ahead and conclude.
Yeah. Thanks, everyone, and take care and stay safe. Bye.
Thank you. Closing
Thank
the
you, everybody.